Good afternoon, everybody, and welcome to Grand Rounds. My name's Tom Farden, and I'm the chair of Grand Rounds. If Fiona can... Okay, so today I'm very pleased to introduce Professor Maggie Bartlett, who I've met for the first time today, so I've just had a rapid tour of where she's come from and what she does. But it's nice to meet you. And Maggie is chair of the Community-Based Medical Education Programme here at University of Dundee. She was previously in Keele University. She's a GP. She manages the SIP GP the GP component of the SIP programme. That's the first 3 years of the medical school degree, and the placements in the PIP, which is the next 2 years. It is often, for me, as chair and convener of this, I want to say a struggle to get the university to come and speak. That's perhaps not the right word, but the university often says that why should we don't want to bring us along to Grand Rounds, no one wants to come and hear, it's all very dry and it's all a bit boring and no one wants to know about it, which I think is not the case at all. I think a lot of us are very interested in the developments in undergraduate teaching because we spend so much of our time as clinicians doing it, and it's critically important to us to know what happens to our students before they arrive on the wards, so we know what they're up to. So you'll know I was heavily involved in the undergraduate curriculum for a number of years and have stepped away to postgraduate education, so I'm very interested to find out what's been going on in my absence, and I'm sure there's been lots of exciting developments, particularly since, was it October, that Maggie came here and started work on our longitudinal integrated clerkship. So, welcome.
Thank you, it's very nice to be here. You all look a very long way away, but I'll get used to that. So what I'm going to be talking about, obviously, is longitudinal integrated clerkships, and I just need to correct you, Tom. I didn't set them up when I came here. We did have them set up. I've just taken that on since I got here. So the GP team has been working on them for a couple of years before that.
Show some time.
So I'm going to start with some educational theory, and I'm sure you'll remember or recognise these big names in medical education theory, but all I'm going to say is that all of these people just basically said that people learn best by doing rather than learning from books. And I'm going to leave it at that for those four. But moving on to these two rather luridly coloured books, which have really informed an awful lot of my thoughts about medical education. Lav and Wenger talk about these two concepts, one of communities of practice, which builds on sort of social learning theory, that people are social animals and everything happens in socially constructed settings, and learning is one of those. And the idea of a community of practice obviously is that people are all working together to learn, to do things, and learn as a part of that community. And in a medical community of practice, not only do students become socialised into the way of doctors and of medicine, they also have transformative experiences that affect their identity. So they develop these professional identities. It becomes part of who they are. The other half of it is the idea of situated learning, that anyone learning to be a professional will learn best in the situation in which they ultimately will work. And a very interesting concept of legitimate peripheral participation, that for learners who are able to participate on the edges of a medical learning system or a medical healthcare environment will gradually, over time, creep in from the edge and become one of the old-timers in the centre. And I particularly like the idea of the old-timers beavering away in the centre and the young ones becoming older as they move in and more experienced. But these two concepts are really very central to the idea of the longitudinal integrated clerkship, and that this theory underpins the educational aspects of the clerkships. So, what are longitudinal integrated clerkships? They've been around since the 70s, but they were really sort of properly defined by an international group called the Consortium of Longitudinal Integrated Clerkships in around 2009. And how they're defined is that students participate in the comprehensive care of patients over time, and they participate in learning relationships with those patients' clinicians. And that's really important, that it's the clinicians looking after patients that they perceive to be their own patients that helps them to learn so effectively. The other criterion for a LIC, which I shall carry on referring to these clerkships as from now on, is that the majority of the core curricular competencies are met across multiple disciplines simultaneously. And that's another key feature. The organising principle being continuity. So it's about students developing relationships which endure over time. So just sort of stepping back a bit into the kind of curriculum that we probably all are most familiar with, the block-based curriculum, and you all know about these, is that students move through specialty discipline blocks that have varying lengths of time, often sort of 4 to 6 to 8 weeks kind of length, over the course of an academic year. The implication being that, whether it's intended or not, the implication is that once they've finished their mental health block, that's that done for the year. They're then learning about surgery and so on. There may be some themes that run across the whole year, sort of underneath all of these specialty blocks, but it is very blocky. And students may spend their block learning everything they think they need to know about mental health, and then they put that out of their mind to go on to learn the next chunk of stuff. So what a LIC does is it has students learning all the disciplines simultaneously. This isn't a very good representation in as much as it makes it look as if they're still separate, even though they're continuous. Actually, it should look something more like some kind of braid or plait, but my IT skills weren't up to that, so it had to stay like this. I'm going to work on that. But the benefit to students is that they're learning all the disciplines throughout the year, so they don't close each one off, they carry on. So logically you can see that by the time they get to the final exams for the year, they've kept up their learning across all of them all the time. So in theory they're better prepared for the exam. The important thing here is that the unit of integration in the longitudinal integrated clerkship is the patient. And that's why I say this picture should be more like a braid. Because students are involved with patients, they're following them through to any healthcare episode, through any healthcare episodes that they have. So they may be working with a patient who on one occasion is a mental health patient, on the next occasion maybe an adult medicine patient, they might become a neurology patient at some points in the year or their life, or they may become a care of the elderly patient. So the idea is that the students stop seeing patients as a surgical patient, but they see them as a patient with a surgical problem sometimes, or a medical problem other times. So what this results in is relational learning, or sort of social learning system, where the student moves from being someone who is filled with knowledge about a specialty to someone who's constructing knowledge in partnership with the clinicians that they're encountering, but also with the patients that they're spending time with. And part of the importance is that the students are contributing to the comprehensive care of their patients over time. So they're not feeling like a spare part in a clinic, they're actually feeling like part of the system that centres on the patient, which helps them to learn. So that this idea of a symbiotic kind of mutual relationship where this knowledge is built by the group of people involved. So, stepping back a little bit to look at the history and geography of LICs. This is a paper that was published in 2016, where this international consortium got together to survey as many medical schools as they could, in as many countries as they could, to try and find out what kind of LICs were going on and where. And what they found was that starting back, comparing things with the early days of LICs back in the 70s, there's been this huge increase in the last 10 years or so, going from actually about 7 in 1980. In fact, that doesn't quite match up to that slide, but now there are 54 of these clerkships. There were 54 in 2015 that got reported to this group. I'm sure there are more, but that shows you the huge increase in interest in this kind of learning. They tried to make this typology to try and define what kind of LICs there were, and came up with a very tidy ABC. The first one, amalgamative clerkships, those are really extended placements. So in those ones, the students aren't following patients in and out of care, they're just in one place for a long time. So it's the longitudinal without necessarily the integrated. Then the next one is the blended LICs, which are where students follow patients in and out over a period of time, but the majority of the core curricular competencies aren't met. So there'll be a chunk of time in a lick, but then there'll be some blocks afterwards for making up the rest of the curriculum. And then there's the all singing, all dancing, proper comprehensive lick, where students are in their lick environment for the whole year and will follow the patients over the course of that year. Looking at a map, the red blobs are the amalgamative ones, and the blue ones are the comprehensive ones. So you can see that the majority of these clerkships are in North America and Australia. And the reason for that is they were set up in a response to rural workforce crises in those areas. And it was a way of trying to embed students or learners in rural areas which were struggling to recruit, so that the students learnt in those areas and were more likely to want to stay in them afterwards. And that was very successful. But you can see those two red blobs in the middle there over Britain. One of those, the big one, is Kiel, where I came from, where we had a 15-week placement for all students in the year, in final year, in general practice. So that was one of these amalgamative clerkships rather than a proper lick. So, in terms of practicalities about how the lick is actually organised to help students learn, what I've done really here is I've kind of taken the general principles rather than any one particular lick. So the students have a clinical home, which is a little bit of an American way of describing it, but nevertheless it does describe it. So that's the place where they're based most of the time. And then if that home is in primary care, then they're going to have this sort of in-reach into the hospitals, whereas if their clinical home is in secondary care, then they would have outreach into the practices to follow up their patients. So here's a rural practice, one of ours, in Dalbeattie in Dumfries and Galloway, where some of our students are learning on a lick at the moment. Another one of ours, this is in Inverness, which is obviously a rural, an urban practice where we've got students learning. But in America, this is San Francisco, there is a lick based in the equivalent of Ninewell, so a tertiary teaching centre. So it's not only about general practice, it's certainly not only about rural practice. And this is Parnassus Hospital in San Francisco, which is where their lick is based. So licks have components. One of the main components are these key patients, or a patient panel, that students will work with and follow, and each student will have their own panel of key patients that they will select with the guidance of their educational supervisors. And the idea is that they have a group of key patients that really sort of represent the curricular aims for the year, and they follow them the whole way through. Then there's the provision usually for some sort of continuity in acute illness. So these short acute care bursts, which I'll talk about a bit more about in a moment. A key component of the curriculum is quite a lot of white space. In the Harvard Lick, they have 30% of white space in the curriculum, which takes a little bit of academic courage, I think, to leave students to their own devices for that much time. But they need it, because the learning is self-directed, and they need to be able to choose what they do, and they need to have space to follow their patients. So if a patient that they're involved with is admitted to hospital, they need to be able to go to hospital without much notice to be involved in the care of their patient once admitted. So it's to allow these transitions in and out of different clinical environments. There needs to be some planned learning, because there are some things that it's just difficult to learn as a whole subject when you're following patients around. So often there are tutorials or sort of set-piece lectures that the students can go to. And then there are the assessments. And for the majority of licks worldwide, the assessments are the same as for students on a traditional programme. So the idea for these students is that they reach the same standards and pass the same exams as their contemporaries. And in many countries such as Canada and America, they have to pass national licensing exams. So there's that externally set standard as well. So here are some examples of key patients. And these haven't come from anywhere other than from my own interpretation of the literature, really, and the proposal that I put in for Kiel and I'm working on here. For each of the specialties that appear in a particular curricular year, here it's year 4, taking each block that the traditional students do, I've just looked at the kind of core clinical material that the students are expected to cover and come up with these. So they're broad brush groups of patients, they're not specific conditions. We need to get away from that sort of tick-boxy kind of approach to patients. But it's so that students can choose from wherever they meet the patients which ones to follow up. And I'm not going to read these out, but you can see that they're sort of broad types of patients. And we've got the same list for mental health and for surgery and for obs and gynae. Looking at a typical week, there's 2 types of weeks. This would be the routine sort of week. And you can see that the students are spending the best part of 2 days in general practice. But then they have got these other opportunities in the week to go and do what they feel they need to do and to follow their patients around, which can extend from early morning till at whatever point in the evening they feel they've done enough. But sprinkled within that, there may be some specialty clinic attendances if their patient goes to outpatients, or if they decide that they've got a particular need to learn about a particular aspect of medicine, like going to a gastroscopy session or something like that, they can go and do that. They do have a tutorial with what we call a regional tutor here, and that's an opportunity for them to talk about the patients they're seeing, a bit of a debrief, something about planning learning, having the regional tutors facilitate transitions in and out of secondary care and those kind of things. And they may have another clinical activity, like, for example, I've just put an A&E shift on here. It doesn't have to be that, it could be something different. But it's something that they feel they want to do that meets their learning needs. So it's very flexible. And for our students on the LIC pilot at the moment here, they have got these days in general practice, but if they wanted to do something different on a particular week, they might have less GP in that week and more in another week, and just be very flexible. Then the other kind of week is an acute week. So in these weeks they carry on doing some of the GP work, they carry on having their tutorial, but they have these short periods of continuity in an acute setting. So the idea is that they would join the junior doctors at the handover at the end of one day, spend as much time as they want to that evening with the juniors, following what they do and helping them to do what they do. And then they would leave at some point, and then join the juniors again at the morning handover, spend the whole of the rest of the next day with those juniors, continuing to contribute to the care of the patients they'd seen being admitted the night before. And again, they could stay as long as they felt they wanted to, or as long as the juniors wanted them to stay. And then in the rest of that week, they've then got opportunities at either end of the day, whatever they're doing in the day, whether they're in general practice or whatever, they've got the opportunity then to go back and see how those patients are doing and have this ongoing relationship with them. And hopefully, if the patients are discharged, they've got the opportunity to go to wherever the patients go next, whether that's back to the GP or into some sort of social care environment or whatever. And then when we come back to the typical week, they may still be following up some of those patients the week after and the week after that and the week after that, as well as the patients they'd already gathered earlier on in the clerkship. So it's all very flexible and directed by the students largely. And then, as I mentioned before, the other activities would be more sort of tutorial-based or specific learning. So things like radiology and pathology, they may well get involved with talking to radiologists if one of the patients that they're involved with needs some sort of radiological intervention. They can negotiate to go along to that as well and see what happens to their patient there. Or they could arrange to have a one-to-one conversation with the radiologist about what happens to patients like theirs in the radiology department. And the same with pathology. And then there are these other clinical areas where students perhaps need something a little bit more set piece in terms of teaching, things like fluid balance, safeguarding, ethical issues, and I'm sure there are many others. So, do they work? Which is a key question. There was what's called a narrative review rather than a systematic review published a couple of years back by a group in Australia. And they looked at about 58 papers they identified which met their criteria. And what they concluded were that LICs did work, that they described them as credible and effective alternative to block rotations. And I've just divided up the areas in which they categorised them as having worked to go through next. So in terms of academic results, the summative assessments, they concluded that at times the results were better. They were usually no different, and rarely were they poorer than students on a traditional block rotation. And just taking one example of one paper, this Paul Worley is one of the kind of big names in LICs worldwide, and has certainly done a lot to promote them. And he and his colleagues looked at the students that were working with them in Flinders in Australia. And what they found was, comparing Year 2 and Year 3 performance over quite a number of years, the LIC students, which is this middle group here, the PRCC one, had a greater improvement in their results between Year 2 and Year 3 than those on more traditional rotations. Moving on to clinical performance, so this is really sort of workplace-based assessment kind of outcomes. I'm not going to read them out, but they found that the students on the LIC did perform better over a whole range of areas than the traditional students. And it was largely about being self-directed, being able to deal with uncertainty, being able to manage their own learning, feeling more able to get involved with the care of patients. This is another specific example. This is the Harvard LIC. And as you can see on here, the LIC students of the darker columns, they just got kind of more experience of seeing patients pre-admission, post-admission, establishing the meaningful relationships with patients, feeling that they could actually make a real difference. They themselves could make a real difference to health and well-being of patients. And interestingly, at this end, they did describe much better feedback from the clinicians who were treating the patients that they were involved in. And that's probably just because of the longevity of the relationships they were having with those clinicians. In terms of students' values and ethics, there's this very interesting finding, just stepping back a little bit into the general medical education literature, that students' empathy erodes over the course of a medical career, generally. And what was found for the longitudinal integrated clerkship students was that this erosion of empathy was reversed quite significantly. And again, this was thought to be due to the longevity of relationships, that students were starting to see patients less as passive tools for learning, more as people with whom they had a relationship. And they had this greater sense of responsibility both to individual patients and the communities in which they were working. It's tempting to think that by being involved with patients over a big long chunk of time, there might be boundary issues, but actually these students were much better at managing those professional boundaries with patients, which is interesting, and more confident in managing ethical dilemmas. This paper goes back to those two brightly coloured books that I showed you first of all, that these students, because they were involved in the narrative of patients' care over a period of time, they did get into these understanding and listening and hearing the stories of the patients. And they did describe these kind of transformative relationships where they developed professional identity more than traditional block clerkship students. And coming back to the idea about the erosion of empathy, this paper looked at postgraduate students who'd been on the LIC and compared them with students who hadn't been. And they found that this patient-centeredness and the maintenance of empathy endured 2 or 3 or 4 years post-graduation, having spent 1 year on a LIC. So, learning experiences. Well, I covered that a little bit with the graph just now. But the students did feel that they ended up with seeing a broader range of patients and a broader range of conditions than the block clerkship students did. And they very much felt that the continuity of supervision was what contributed to their increasing knowledge, and that they, by getting frequent, incrementally progressive feedback from clinicians that they had ongoing relationships with, their knowledge could be more managed and sort of just gently brought on than being hit with a load of stuff in a 4-week block and then sort of moving on. And in terms of practical tasks, so procedural skills, that these tasks were tailored to the students' needs, so they also felt that they got better learning around procedural tasks. And again, coming back to the relational aspects of learning, being treated as a near peer by experienced doctors actually did a lot to bring them into the communities of practice and to help them to develop their professional identities. This is paper that I wrote while at Keele with some colleagues, and what I like about this is that the students describe themselves as knowledge leeches. This is their term, that in the traditional block clerkship they felt that they were just leeches of knowledge, that they kind of got in the way and detracted from patient care and were a bit of a nuisance. But by taking part in the 15-week-long clerkship, they actually started to feel they were part of a team. And why that's particularly relevant is that up until now, it was thought that students needed to be in a LIC-like environment for 40 weeks to start to feel part of the team, but we demonstrated that actually it happened after 15. And I'm just going to digress a little bit here, just to share this one quote from that paper with you. And what struck us about this was that the implication of this story was that the student had never really seen anyone get better. So in hospital care, they'd seen very ill people, but they'd never seen the transformation back to a kind of normal person, a non-patient. Likewise in general practice, they might possibly perceive that they don't see anyone who's really very ill, but this guy was very ill. And the student witnessed that transformation from illness back to health. And there's a bit of the quote that I've left out, but what the student went on to say was that had he not been in that 15-week placement, he would have seen that man once, and then the man could have died, and he'd never have known. And that was quite an important thing to this student, that he did actually find out what had happened to this very unwell man. So, coming back to the review paper, clinical supervisors like teaching on a LIC, and that's again linked to relationships. They like the collaborative working relationship. They liked the longevity of the relationship. They got satisfaction from seeing a student develop over time. And 83% reported that their professional lives were more satisfying as a result of these enduring relationships with a student in one of the papers. And everywhere there's this competition between patient care responsibilities and teaching responsibilities, and it was found that tension was reduced amongst clinical teachers in these kind of clerkships, because they actually did appreciate the contribution the students were making to clinics and on wards, and so it felt more collaborative. Patients, they like LIC students, they like relationships, they like the idea that they've got continuity. And there was quite a lot of description of where patients had been admitted acutely, and actually it was the student who knew them the best, who could contribute to the history giving, who could share clinical information with the receiving clinicians, and the patients valued that. It took some of the pressure off them to remember all about their medication and their past medical history, and they could share that. And career outcomes. So a lot of the papers talk about these positive impacts on rural and community career choices. We have to bear in mind that much of the literature around this comes from Australia and Canada and the States. And what they describe as rural is not the same as what we describe as rural. So for them, a rural hospital is what we might view as a DGH in an urban environment. So we have to be a bit careful about how we interpret that literature in this country. But nevertheless, there is this impact on rural and community recruitment. And the longer the students are in those environments, the more likely they are to stay. So coming back to a bit more theory, how LICs work. and these two books, which I won't go into again. But to summarise what I've been saying, it's about these meaningful and authentic roles for learners. And this idea that patients start to matter to students, that they don't see them as transient objects, they start to matter. And that the students also matter to their clinician teachers. And communities matter to students, and students matter to communities as well. But another interesting thing is here the benefit on clinical reasoning. Because students are seeing the consequences of clinical decisions, they learn better about how to make decisions. And then learning science effects, which I'll just talk about very briefly, information that I've taken from this paper. And there's these three concepts of spacing and two concepts of spacing and interleaving, which are used throughout education. It's not about adult education only. Primary school teachers make use of these ideas, that by returning to a topic at regular intervals, you get better learning, which is the basis of a spiral curriculum later on. And if you want to get into sort of the cognitive aspects of learning, it's about reactivation of prior learning, that the more you retrieve stuff out of your long-term memory, the more efficiently you can continue to retrieve it. And the other thing is about interleaving, where tasks and topics are mixed up. So by constantly moving between tasks and topics, you're comparing and contrasting and trying to extract general rules, because that's how humans are made. We like rules and patterns. But by trying to extract these rules and transfer them to each new situation, we get much more efficient at bringing things out in and out of our long-term memory. Students do comment that it's harder to learn on a lick, and that we know from cognitive psychology that this interleaving does make learning harder in the moment. But what it also does is it reinforces learning, so that it becomes to this idea of desirable difficulties. If you have to struggle to learn something, actually you're going to remember it better. So by this constant comparison, you're working harder and it's working better. And then questioning inquiry. If a student has to identify their own questions to answer and go and seek those answers, that's going to work better than just being sitting somewhere and having someone tell them stuff. Right, we come on to closer to home, the Dundee lick. Just a reminder of these different kinds of clerkships. The Dundee lick pilot is a comprehensive lick. And I'm triumphantly putting it there as a little blue blob, which is related to the fact that it's based in primary care, that it is comprehensive, and it's got a very small number of students at the moment. And there it is, just highlighted for everyone to see. We've only got 7 this year. So the pilot started in the academic year before this one. We had 7 students in that year. We've got 7 in this year. The students are in the lick for 40 weeks. They spend roughly 60% of their time in primary care and 40% in secondary care, but that's flexible and adaptable. Word's starting to get round, and we've had 11 applicants for the new academic year, which we're pleased about. We believe that the lick philosophy is very much in line with these 2 documents that we're all working with locally. So it seems to fit in with the spirit of the times. And a couple of things from our own students' experiences. It's working for them in the way that we hoped it would. They're enjoying the continuity. They're feeling that they're seeing the whole story and the big picture in the community and in healthcare. And one student's made this comment that it's adult learning in a nutshell. We've got another who said that they were feeling the buzz of realistic medicine, which was nice to hear. And I'm just going to describe one student's experience with one of their key patients. This was a patient they'd seen lots of times in general practice, somebody with brittle COPD, who was obviously on a lot of steroids for that condition and had become Cushingoid and were having a lot of problems with back and joint pains, which the student had been involved with over time. This patient suddenly developed new seizures at the age of 50. The student followed the patient on that admission and clerked her in on the ward and was involved in the ward care of her. But she died a few days later. And what the student's reflection is this, which obviously is very powerful learning for that student. And the student describes this patient as someone close, I don't know if it's a male or female student, but someone close to the student and hadn't had that experience before. As well as that, they'd learnt, I would predict, a lot about management of seizures and investigation of seizures in a middle-aged person, lots about COPD management, lots about side effects of medication. One of our LIC students is published. He wrote a letter which was published not long ago, very much seeing himself as having been an agent of change. So in the vanguard, in the first cohort of LIC students, very much involved in something that was developing and being proud of that. And I'm going to just describe one tutor's experiences. I was down in Dumfries and Galloway last week talking to the tutors down there. And the tutor was telling me with a little bit of embarrassment in a way that he'd got a patient who had got mesothelioma, and the family were very anxious about this whole situation, and he didn't feel he had time to commit as much time as he wanted to this family. So he felt he was using the student by sending the student in to go and spend time with them to talk about the management plan and the likely progression and that kind of thing. But actually, I thought that was exactly what the LIC's supposed to do. So the GP's time was being freed up, the patient's needs were being met, the student was learning and contributing to the health of their patient, to the healthcare of the patient, and supporting the family, which felt like a good thing to me. So I was able to reassure the GP that that was okay. So, a new model of clinical education. It's something that's developing. I know of many schools in the UK that are wanting to have a LIC. There was a national meeting in Sheffield about 18 months ago where we all got together and talked about these, and it was represented by the majority of the UK medical schools who want to go down this route to some degree in some parts of their courses. I did a search last night, just putting in longitudinal integrated clerkship into one of the medical education search engines, and 553 papers came out. So that's a lot, and I think there's probably several more every day. And I think it's a good thing that we're leading the way in this, and that we will be publishing about it, I hope, and that we will be a model for other people in the UK to turn to and come and ask advice from. So I'm proud, and I'm happy to take questions.
Thanks very much. Interesting stuff. It's 24 years since I went to medical school this year, which seems ludicrous, but true. And I remember my time at medical school. Actually, I don't remember much of my time at medical school, but the times I do remember, the bits I value is the bits when I felt useful. And I think that still pervades through. You can look at students who come onto the wards or in clinic and they're bored because they're not very useful. They just sit there, not really doing much. But if you give them stuff to do, give them a role in the ward, or they are more interested, they're more likely to learn things. And I think that what I get from this is that you're giving them a role, a really important, active role, and they buy into it. Do you think it's for everyone? You've got 11 people wanting to do it. I can think of a couple of medical students over the last 10 years who might use their white time for something else other than self-directed learning.
Well, at the moment we're asking for volunteers, and I suspect it's going to continue that way. Although the ScotGEM students, they're year 3, all of those students will do the Dundee LIC. That's the plan. So we're going to make all of them do it. They won't have a choice. And I think it probably is for everyone, but they probably don't realise it.
The ScotGEM people are all graduates, by definition, and therefore more mature in age, even if not in approach, but let's assume they are in approach as well. The Americans all go into medicine as a postgraduate entry, and I'm not certain, I don't know about the Australian system. Do you think it's more of a more adult learning process? So you think that that's why it will work for the ScotGEMs for everyone?
Yeah, it's true that most of the literature comes from places where they do have graduate entry medical schools. However, there was a review of all of the literature about the types of students who do well on a LIC, and there was no conclusion drawn about whether graduates do better or don't. Thinking about the students that we've had on our LIC pilot, some of them have been school leavers and have done extraordinarily well. And I suspect if we look at a group of graduates, you'll get some who do and some who don't. I think it's about self-direction. It's a little bit about having the determination to go and negotiate these learning activities. Some students do seem to prefer that more passive, hand it to me on a plate kind of approach to education. I guess if we're going to do it for a whole cohort, we have to be very careful about how we brief them and how we set expectations. I think the other thing is when you are working intensively with one supporting clinician, it is more difficult to hide. And so people do tend to work better when they're being scrutinised more closely and continuously, which is important.
I'm hogging the questions, but I find it very interesting. How do you go about making sure that there aren't big bottlenecks? It struck me from your week 1, week 2, week 3 that you said people could, that you follow your patients in. One of the things we find is that if you have one student, great. If you have 2 students, bit of a tight thing. If you have 17 patients all turn up at once, that's impossible. So is there some method that you avoid that everyone decides to do an A&E shift, or everyone comes to AMU with their patient that day and it's just too much for us to handle?
I think it would be very unlikely that everybody would turn up at AMU on the same day, because
I don't know, it seems like it, doesn't it?
but they're not following patients, are they? So there will only be a very small number of patients that come from each practice over the course of a week, I would imagine. So if a student's linked with a practice, they're not going to be in and out of AMU all the time. They'll only be there when they need to be there, and they'll be only involved with their patient. So when their patient moves on, they'll move on too. And the same is true of clinics. If a student's following a patient to an ENT clinic, for example, they'll only really see their patient.
So they would just come to the clinic to see Mrs. Miggins, who's there. They wouldn't stay for the whole clinic.
No.
Okay.
But if they had a gap in their knowledge and they wanted to come and sit in a whole ENT clinic, then they would set that up in advance.
Right, so it's not I get someone turned up to my clinic this afternoon and they say, I'm here to see Mrs. Miggins, but can I stay for the rest of it?
That shouldn't happen.
Okay.
So they'd be with their patient, and when their patient leaves, they would leave with their patient, because they would then want to talk to the patient about what had gone on.
Does anybody else have any questions? I'm going to bring you a microphone so that they can hear you in Perth. I'm recording forever.
Thank you. I'm really interested in the empathy business and the way you were saying that, during the medical school training, am I right? You were saying that it drops, and you're saying there's evidence here that it doesn't drop. And as humans, we're not very good at uncertainty. And do you think that is the cause of it, that because we don't know what happens to patients after, if we're just seeing them for a very short time on blocks, we sort of, in order to stop wondering what happened to that patient, that's where the empathy drops. Whereas you gave examples there of someone who saw a patient get well and someone who saw a patient die, and there was no uncertainty about what happened to that patient.
I'm not sure that it's that, although that could be part of it. My own feeling, having read a lot about this, is it's more to do with this idea that patients are seen as passive tools for learning, so that when you're on a 4-week block, and maybe you've got tick box things about the number of patients you've got to get with certain conditions or whatever, the core clinical problems, they go through with that list and try and tick them off. The patient becomes that; they become a passive tool for learning, and it's about meeting the criteria of the course and getting your Rocky signed off or whatever it is. And I think that inevitably leads to people viewing patients as a commodity, for want of a better word for it. Whereas if you're following that patient over time, you're not going to see them in that way, because the learning follows the patient and is linked to the patient, rather than the patient being a tool for the learning. I think that's what it is. No students spend the whole of a programme in one of these clerkships. It's always usually 1 year, or part of 1 year. And what happens is that the empathy erodes. I think it's over the first 3 years of a medical course. And what we know about the clerkships is that they not only stop that further decline of empathy, they reverse it. So it's even more than it not happening. It's actually reversing it.
Any more questions? Anyone? Oh, yes, Helen.
Hi, thank you. It seems like an amazing programme. I was just wondering if they've done any sort of similar things at a postgraduate level, because you often see that sort of continue throughout, especially throughout kind of foundation year and core medical training, that people don't get the opportunity, which is amazing to follow through patients in this way.
Mm-hmm. Not that I'm aware of, but there are various things. In fact, somebody rang me up a couple of weeks ago, a radiologist from the Western Isles, who thought that a lick for teaching radiology trainees would be a good thing. I had to say I couldn't quite get my head around how that might work in that situation, in that specialty, but it's great that people are starting to think about it in a postgraduate setting.
I can think exactly how it'd work for radiology. It'd be fantastic. Radiology trainee gets to come and see patient, works out why we want the test, does test, comes out, see what result of test is. I think that would be a fantastic thing, particularly for radiology. Okay, I think we've come to a natural conclusion. I'd like to thank Maggie for a really interesting talk. Thanks very much for coming. Next week, Graham Kramer and Nicola Stevens are going to have a second crack at doing the talk on shared decision making. Last time they got shooed out by a fire alarm. Hopefully they won't have another fire alarm next week. So please do come. That's the last grand round of this semester, and then next semester starts way after the Easter break. We have a full programme. It's completely full. So if you want to do a grand round, if you're listening in the ether, then the next available slot is September. So that's great. So thanks everyone for contributing. Thanks again, Maggie, and see you all next week.